Hi, everyone. Welcome to this session about X-Linked Cerebellar Ataxias. It is my privilege to introduce our two speakers today. So first, we have Dr. Ginevra Zanni, who is a neurogeneticist at the Bambino Gesù Children's Hospital in Rome, Italy. Her scientific career has been devoted to screening and identification of new genes involved in rare neurodevelopmental disorders and the characterization of physiopathological mechanisms and genotype-phenotype correlations. She currently mainly works with pediatric ataxias and neurodevelopmental disorders. And our second speaker, who will be joining us a little bit later today because he's currently in the clinic, is Dr. Enrico Bertini, who is a pediatric neurologist leading the clinical diagnostic and research laboratory unit of the neuromuscular and neurodegenerative diseases and the laboratory of molecular medicine of the Bambino Gesù Children's Hospital in Rome. He is a contract professor of pediatric neurology and has worldwide known expertise in neuromuscular disorders. He is a member of several scientific societies and is a member of several scientific committees and of several patient organizations, including SMA and mitochondrial disorders. He has long-lasting experience in the organizing of teams, providing funds for care, research, and many international collaborations. And with that, I will turn the floor over to Dr. Zanni. Thank you so much for joining us today.
Thank you, and for inviting me to speak about X-linked cerebellar ataxia. And it's a privilege for me also because the National Ataxia Foundation chose our center as a center of excellence. And so I will talk about X-linked cerebellar ataxia, where were discovered and how does it work. So X-linked cerebellar ataxia are a spanning group of genetic heterogeneous and clinical variable condition characterized by cerebellar phenotype and caused by gene variants or genetic imbalance on the X chromosome. More than 30 genes on X chromosome, mainly encoding for proteins involved in cerebral development and synaptic function, have been associated with the X-linked inheritance. So the neurological feature include hypotonia, developmental delay, abnormal eye movements, ataxia, and other cerebral signs. The defect can be isolated, and so we are talking about pure X-linked congenital or cerebral ataxia, or associated with neurological, neuropsychiatric, or extraneurological feature, and we talk about syndromic ataxia. And XLCA can be further classified into progressive, slowly progressive, or non-progressive, according to the clinical course. The inheritance can be X-linked neurorecessive, X-linked semi-dominant, or X-linked dominant. What I mean by this X-linked inheritance, in the recessive mode, we have only affected males, no male-to-male transmission, and female are hereditary carrier. In the semi-dominant mode of inheritance, males are more severely affected than females. There is the role of X-linked activation in females. And as for any genetic disorder, variable expressivity and penetrance is present. In the X-linked dominant mode, apparently more affected females than males, but in fact it's because there is a lethality neutral for males, and only males with hypomorphic variants can survive and express a phenotype. So it's a long journey. Started in 1958, when these two authors, Malamud and Cohen, described two families with an X-linked pedigree. And the description was clinical and only based on the family history. The same in 1987, other two authors described two other disorders, X-linked by pedigree observation and reported clinical feature of these syndromes. And these were progressive ataxia, and in the online Mendelian inheritance, they were classified as SCA X2, 3, and 4. With the advent of linkage studies, 1996 and early 2000, 3 families with non-progressive X-linked ataxia were described and mapped to the X chromosome long arm in 3 different loci. And finally, the first family was solved by whole exome sequencing. Then we had to wait for whole genome sequencing to solve the second. And the last was solved by long-read whole genome sequencing. And now I will go in detail. So the first was described in 1958. It was a male child, first seen at 2 years and 4 months, because unable to walk and talk. And he had marked ataxia and tremor of the extremity. And when he was 7, he developed convulsion and apnea and expired 2 days later. And then a second family was described with similar phenotype. And what happened in the first case is that the mother reported that her sister's son was showing similar symptoms several months after the death of this patient. And here we can see the autopsy with the cerebellum of the patient, which is markedly atrophic. So so this is the family described in 1987, and here also we have a big pedigree with several affected males over generation. And the patient developed progressive cerebellar dysfunction, cognitive impairment, deafness, optic atrophy, and adrenoleukodystrophy. And the disorder followed a progressive course and was associated with feeding problems and worsening of the ataxia, and led to death in childhood. This other same situation with all male affected X-linked mode, recessive mode. And so in this family, 12 affected males over 3 generations, early onset ataxia, and pyramidal tract sign, and slowly progressive out to the adult onset dementia. And so this is the first non-progressive congenital ataxia described in 1996. And actually, after many years, actually 20 years after, it was found to be a double trouble, meaning that 2 X-linked genes, both involved in cerebral development, were identified by whole genome sequencing. A pathogenic ABCD7 variant and a deletion in ATP7A. And this was the second Italian family, small pedigree, but with clear X-linked recessive inheritance. Maternal uncle and the proben affected, again with non-progressive congenital ataxia. The neuroimaging studies showed global cerebellar atrophy that was not evident in the first years of life, but showed after 2 years of age. And this is the maternal uncle with the atrophy. And it turned out that by by exome sequencing that the gene was a calcium pump, extruded calcium from the cell, and it was a missense variant identified in this family. And then there was the third non-progressive congenital ataxia family of Norwegian descent. It was mapped in the long arm of chromosome X by linkage studies and was recently solved by long-read genome sequencing. These are unpublished data, and actually it consists of a complex palindromic insertion of autosomal segments of other chromosomes in the X, in this XQ27 palindrome, which is a region of genomic instability. Here you can see the pedigree, show a clear X-linked recessive inheritance, and the cerebellar atrophy, very marked cerebellar atrophy of the proband. And this is a graphic overview of the X chromosome, showing X-linked intellectual disability syndrome. And in green, I've underlined the genes that are usually, constantly, or exceptionally associated with a cerebellar phenotype. So I just presented the pure X-linked SCA, the SAs 1, 5, and 6, non-progressive X-linked congenital ataxia, plus the other syndromic, syndromic and also lethal case, or the case with dementia. But now I will talk about syndromal X-linked ataxia, and afterwards I will also talk about the ataxic variant of X-linked adrenoleukodystrophy. And these are some of the other genes involved in ataxic phenotypes in X-linked intellectual disability syndrome or other metabolic syndrome. So oligophrenia 1 syndrome, it's an X-linked semi-dominant because it affects male, and in carrier females, mild deficits are sometimes present. It's characterized by neonatal hypotonia, motor delay, moderate to severe intellectual disability, speech delay, ocular sign like strabismus, nystagmus, and ophthalmoplegia, cerebellar sign, and cerebellar hypoplasia is predominant in vermis. And the behavioral phenotype is usually hyperactive, anxious phenotype, and seizures are present in more than half of the case. Less frequent features are mild photoreceptor atrophy, microcephaly, tall stature, genital hyperplasia. Normal cerebellum can also be present in some cases, and partly normal cognitive level has also been reported. Autism, and more than 35 cases were reported to date in the literature. So the characteristic neuroimaging is the agenesis of the vermis more than the cerebral hemisphere, and the enlarged cerebral ventricle, sorry. And also there is a characteristic facial appearance. This is one family, one with 5 affected males. This is another family with 2 affected males, another family with 3. And long face, prominent forehead, infraorbital creases, deep set eyes, and upturned philtrum and large ears. The gene can be deleted, or different kind of variants have been described in different domain of the proteins. Normally, it's a loss of function variants. And oligophrenia encodes for the protein that is implicated in neurogenesis, neuromigration, synaptic function, through the signaling of a kinase, a Rho kinase, which has a substrate called MYPT1, which is influencing the skeletal, cytoskeletal contractility, actin myosin. And actually, what they saw in the oligophrenic knockout mouse model is the immature dendritic spine and enlarged ventricle, but apparently normal cerebellum. We tried to translate the therapy which had function on the mouse model with an inhibitor of the Rho kinase, which is hyperactive in this disease. And so we reprogrammed and differentiate patient IPS. And here you can see that the oligophrenic in green in the control cell neurons is absolutely absent in the patient. And also the appearance of motor neurons, cerebral granule cells, and glutamatergic cortical neurons are disrupted and immature in the patient on the right column compared to the control on the left side. And this is the appearance of the control neurons and of the mutated neurons with a reduction in the, from the morphological and from the point of view, there is a decreased neuric length and number of branches, and these neurons look very like a neuron. And so with this inhibition of the Rho kinase, we restore the level of phosphorylation of the substrate. We corrected the morphological phenotype. So we have here on the left side the control untreated and the patient. And with the treatment, we see the improvement of the morphology of the neuron, similar to the control. And we have also rescue from the synaptic vesicle, which are these red dots that are almost absent in the patient and reappear after treatment with the ROCK inhibitor fasudil. And the good news is that the fasudil was approved in Japan and China in 1995, but was not available in Western countries. And there was also a derivative of fasudil licensed in 2005 for local treatment of glaucoma. But this year, oral fasudil is under clinical development in the US and currently in phase 2 for amyotrophic lateral sclerosis. And it will soon go on into phase 3. And it's a safe drug. So now I'm talking about another syndrome called CASK syndrome from calcium carbonate dependent serine protein kinase. It's an X-linked dominant, mainly in females, but also hypomorphic male variants have been described. Many variants actually in the last years. And The lesions are as frequent as non-synonymous or stop variants, mostly de novo. And the characteristics are pre- and or postnatal microcephaly, clinical non-progressive pontocerebellar atrophy, simplified cortical gyrate, several severe motor delay, hypotonia, severe intellectual disability, ataxia, unsteady gait, dystonic movement, optic disc reticum abnormalities, congenital nystagmus is more frequent in males. There can be feeding problems, lip disturbances, seizures, so later are less frequent feature, such as spasticity or respiratory abnormalities. 197 patients have been reported to date. And there are other CASK-related phenotypes that I'm not going to talk about. And neuroradiological and facial feature, here we can see the cerebral atrophy marked and the flat pons and the simplified cortical gyri with this dragonfly appearance of the cerebellum and the enlarged ventricles. And the facial phenotype is characterized by hypothyroidism, flat nasal bridge, large ears, and micro neck. Another syndrome called Christianson syndrome is an X-linked semi-dominance also, and which affect males and carrier female can present milder deficits. Development delay again, hypotonia, a progressive clinical course, in contrast to the previous two, oligophrenia and CASK syndrome. Postnatal microcephaly, absence of speech, intellectual disability, early onset epilepsy, motor regression, trunk corrugate ataxia, hand dystonia, eye movement abnormalities, profuse drooling and swallowing difficulty, gastroesophageal reflux, justice pattern disorder, frequent smiling with episode of an unprovoked laughter, Angelman-like. And a total of 95 Christianson syndrome cases were identified, reported in the literature. And these are the main manifestations. So the neuroimaging show the progressive hypoplasia and progressive atrophy of the cerebellum and pons, and elevated levels of glutamate-glutamine in the basal ganglia by MRS spectroscopy. And there is also a characteristic facial appearance with a flat occiput, frontal upsweep, strabismus, open mouth, prominent jaw, thin and gaunt face, low nasal septum, hypotonic face, and open mouth. So to summarize the genes we have presented are involved in synaptic, pre- and postsynaptic function, in cytoskeletal dynamics, and in cell adhesion and transsynaptic signaling, synaptic protein synthesis and translational regulation, and calcium homeostasis and signaling. But not only, because all the proteins are multifunctional. And so this is another syndrome, which is Oira-Riderson, which is due to a gene involved in telomere length maintenance, but also other function. And the syndrome is characterized by bone marrow failure, intrauterine growth retardation, microcephaly, immunodeficiency, increased susceptibility to various types of cancer, and cerebral atrophy. Skin changes may appear later in childhood. And so this is the cerebral atrophy again. And here is the reduction of the telomere length in 2 patients, male. Another X-linked syndrome with cerebellar phenotype is the XQ28 duplication syndrome, which is not surprising because we have found many genes involved in cerebellar development in this region of the chromosome. And it's characterized by moderate intellectual disability, cerebral hypoplasia, hypoplasia of the corpus callosum, seizure, microcephaly, and dysmorphic facial features such as large ears, high forehead, abslenting papillar feature, epicanthal folds, strabismus, and thin lips. So, and then another X-linked cerebellar ataxia syndrome with or without sideroblastic anemia is an X-linked recessive mode of inheritance characterized by infantile to early childhood onset and non-progressive or slowly progressive cerebellar ataxia, mild anemia with hypochromia and microcytosis. The gene, it's localized, I mean, encodes for a protein or localized in the inner mitochondrial membrane and is involved in iron homeostasis availability. And so you can see here the iron ground around the nucleus in the sideroblast. And another X-linked syndrome is the Ginevra, which is a rare also type of Ginevra syndrome, characterized by the typical cerebellum brain malformation of reverse syndrome called the Molar-2 sign. And family was reported with 8 males with severe to profound cognitive impairment. 3 had died of recurrent infection, and 5 patients had post-axial polydactyly, and 3 had juvenile onset pigmentosa. Here we see the polydactyly, and here the molar tooth sign characteristic of the X-linked Ginevra, of the Ginevra syndrome in general. And so this is a rare, apparently rare manifestation of the X-linked adrenoleukodystrophy, which is the most common inherited paroxysmal disorder due to mutation of the ABCD1 gene. Most common phenotypes are severe cerebral demyelinating form and adrenomyeloneuropathy. The ataxic variant was first described in 1982, and 28-year-old man developed slowly progressive dysarthria and gait disturbance, spasticity, all 4 limbs, without intellectual, visual, auditory, sensorial dysfunction. No sign of adrenal hyperfunction were found. However, analysis of fatty acids and showed an increase in the very long chain fatty acids compatible with the diagnosis of adrenoleukodystrophy. To date, 16 patients, including a few females, have been reported with ataxia variant and ABCD1 mutation, and only 2 of them had abnormal, very long chain fatty acid level in the blood. Here we can see the enlarged cerebral ventricles, the cerebral atrophy, and also white matter changes in the cerebellum. So now, how are X-linked cerebellar ataxia diagnosed? Of course, anamnesis and family history, neurological and motor assessment. For more than 10-12 years, we used the SCALA scale, and the Bailey test is used for any patient. And Kinect-based gait analysis is used to evaluate the levels of ataxia severity. This is published by our group. And in the neurorehabilitation department. And then neuroimaging studies of the cerebellum with particular attention to brainstem and cerebral cortex, can be fundamental for the differential diagnosis between X-linked cerebellar syndrome and other non-cerebral X-linked disorder that can present with ataxic syndrome, such as art syndrome, characterized by sensory ataxia, deafness, and neuropathy. And of note, patients with normal cerebellum are reported ataxic patients. The clinical and neurological follow-up is necessary for the assessment of the necessary history of the condition. And genetic testing is recommended for patients with neurological documented cerebral disorders, or even if attacks even if the neuroradiology is normal, but the ataxia is present and the family history is indicative or suspicious of X-linked inheritance, but even in sporadic male patients. And especially when 2 or more dysmorphic features are present. So it's better to perform the usual workup, standard karyotyping, array CGH or MLPA for specific genes like CASK and Christianson. Next generation sequencing studies, such as ataxia sequence panel, whole exome sequencing, or short or long read whole genome sequencing if necessary, and all the previous exams are negative. And even a new technique, it's called optical gene mapping, is a useful diagnostic tool. And also inactivation study are sometimes useful in affected female carriers. Metabolic workup and nerve conduction studies to exclude X-linked metabolic or neuromuscular cause, such as X-linked pyruvate dehydrogenase deficiency and X-linked dystrophinopathies. An assessment of multi-organ involvement and the search for associated problems and minor anomalies, neurosensorial deficits, seizure, autonomic dysfunction, spasticity, scoliosis, etc. is important because most of these conditions are syndromic. And a cognitive and behavioral assessment is essential because there is a frequent association with developmental cognitive delay, and the normal routine scale are not sensitive enough to demonstrate the involvement in cerebral ataxia or of specific learning problems, or like the cognitive cerebellar cognitive affective scale developed by Jeremy Schmachman is very useful. And then quality of life questionnaire to explore sleep, fatigue, pain, and other aspects of the patient life. And biomarkers, this is especially useful for neurodegenerative disorders. And now about the management of X-linked cerebellar ataxia and who is at risk. So patient management, of course, there can be target therapies, for the moment very few, such as now in development for oligophrenic syndrome and hematopoietic stem cell transplant for Euler-Iderson or X-linked adrenoleukodystrophy, but not the ataxic variant, I believe. And then, of course, eye surgery, antibiotic drugs, scoliosis surgery, etc. Disease modifying and symptomatic therapies. Supportive care by multidisciplinary specialists in relevant field to improve quality of life, maximize function and reduce complication, physical, psychological, speech therapy, occupational therapies, and so on. The surveillance and follow-up, for example, cancer predisposition in Euler-Iderson syndrome, scheduled examination by the multidisciplinary care provider to identify unrest imaging issue and disease progression or improvements. Agents or circumstances to avoid triggers known or suspected to be associated with activation of cerebral disease, including head injury or other, for example, for epilepsy, and drugs to avoid. Nutritional indication, food and oral nutritional supplementation, foods to avoid. And more importantly, rehabilitation strategies should be planned for motor cognitive behavioral deficiency, such as also by the use of neuromodulation and computer interfaces, video games, wearable sensors, and in development. And also important is the referral to networks of professionals for expert advice. In Europe, we have the European Referral Networks on Rare Disorders, and there is an online platform for clinical case discussion and also molecular therapy or in progress, like the one for cancer therapies. And rare disease patient registry and natural history studies are essential. And I've been in the NIH trial website, and I only found this coordination of rare disease at Stanford serial recruiting for X-Linked Cerebellar Ataxia anemia for national history studies. There is no other clinical, no other trials ongoing. And the involvement of patient organizations and communities like National Ataxia Foundation, Ataxia UK, and the Italian Ataxic Syndrome Association, which is absolutely fundamental in the care pathway for research, guidelines, development, policies, and trial readiness. Now, who is at risk? Given the excess of male with ataxia, the scope of condition is progressively underestimated, and families of patients with or without neurological evidence of a cerebral disorder should be counseled for high risk of X-linked inheritance, and also sporadic male patients. If the female is a carrier, the risk to male offspring inheriting the disease is 50%. The female offspring having a 5% risk of being carried. If a male is affected, female offspring will be all obligate carriers, and male offspring we do not inherit the pathogenic mutation, of course. If the genetic cause is detected, neonatal diagnosis can be proposed. So this is the new paradigm. Also, very, very important, from the disease-centered care to patient and family-centered care, from what is the matter to what matters to you. And I thank the ataxia community to have been able to celebrate September 25 as the International Ataxia Awareness Day. And all this to make the patient journey easier, from the start of symptom to the correct diagnosis, and all the support from the rare disease community and professionals. For further readings, these are some books we have written together with Dr. Bertini and other colleagues. I've been studying pediatric ataxia with Dr. Bertini since more than 25 years, since 1998. And so the acknowledgement to all the patients and their families, which always support our work, and these are 3 colleagues that are not anymore with us, and I want to thank you, all of you, and also these other colleagues, Professor Carafoli, Professor and Valente, which we have in the last decades shared all these work and patients. And I want to thank the National Ataxia Foundation and the Ataxia Global Initiative, which is a worldwide platform for clinical research in ataxia. And these are the sponsors that have been supporting my research.
Thank you so much, Dr.
I'm
Zanni.
ready for taking questions, and Dr. Bertini too.
Thank you so much, Dr. Zanni, for a fantastic presentation. And thank you, Dr. Bertini, for joining us. We're going to be opening this up for an open Q&A now. So just a reminder for attendees that you can put your questions in the bottom of your screen. There's a button called the Q&A button. If you click on it, you can type your questions in, and we'll get through as many questions as we can in the next 15 minutes or so. So the first question we have submitted, is it possible for someone to have ataxia, but for all of the genetic tests to come out negative or inconclusive?
I can answer.
Yeah, go ahead. Ginevra.
Yes. So, for example, the family that I show with the palindromic insertion, they were followed up since the 70s by Professor Oppitz and Professor Neuhauser. And they were without a diagnosis until we had the technology, which is the long-read whole genome sequencing. Not even with the short-read whole genome sequencing, we found abnormalities. It was all normal, but we knew it was an X-linked disorder by the pedigree and the fact that only males were affected over several generations. So it must have been in X chromosome, but we didn't know where. I mean, exactly what, maybe where, but not exactly what. And so it's possible that the genetic tests are not able to identify. And I think that from a recent survey for ataxia, I think that, yes, almost 40% actually of families or patients are still without a molecular diagnosis.
So as a follow-up question to that, because it sounds from what you're saying, as the technology changes and becomes, we're able to find different mutations and other explanations, that there's more diagnoses available. So if someone, let's say, received a general ataxia diagnosis 5, 10, 15 years ago, would there be benefit for them to talk with their neurologist about getting a new round of genetic testing for the newer disorders that have been discovered?
Yes, of course. We continuously reanalyze also the data of the genome or exome sequencing, because new gene can come up, or I mean rare, sometimes very rare, ultra rare. So very difficult, and we have platform like the one called Ginevra, where we can post a new gene and find maybe patients in the other side of the world, and trying to collaborate to study the functional aspects and the clinical aspects of new syndrome. New syndrome are continuously
Yeah.
coming.
Well, it gives me a lot of hope to know this research is being done and that more genes are being discovered. So thank you for that. One question from me, if there are maybe people in this audience who want to get involved with research, trying to identify new genes, what's the best way from the perspective of researchers like yourselves for them to get involved with your research in terms of laboratory studies, trying to find new genes? What's the best way to go about that? Do they email you? Is there phone numbers they can call? What's the best way for them to reach out?
We are as expert now. We have been appointed by NAF as national expert for excellence, but this is for the especially for the rehabilitation aspects. Concerning the way we can normally patient contact us through the European reference networks or through the Orphanet website.
That's very good to know. For folks who are not as familiar with Orphanet or the European reference networks, could you tell us a little bit about those?
Yes. The Orphanet is, I mean, it's a platform where professionals are listed and their expertise, the kind of genes they are testing, the kind of project they're involved in. And this is one way. So you type your, but then you have to have a diagnosis. Then you have all these networks of undiagnosed disease in the United States and Europe. Undiagnosed disease program. So if you are without the diagnosis, you can address. So it depends. If you have the diagnosis, you can find the professional through this website. And then there's the European reference networks also, which has a website for rare neurological disorders. And there's the Ataxia Global community, which will meet next November in London in the next few weeks. And this also, they have a website.
Well, thank you for telling us a bit about that. I'm not seeing any other questions in the chat, so maybe we could end with your clinic, as you mentioned, has been recently designated an Ataxia Center of Excellence. Could you tell us a little bit more about the type of care that you provide at your site and the type of work that you do?
Enrico, I think the question for you.
I can answer to this if you want, yes. So, well, we decided, to create a center with different units and put together the efforts, dedicated them to ataxia. So we have a unit of rehabilitation that is dedicated to the follow-up of ataxic patients. Now that we are starting with clinical trials, it's relevant. But also, we know that rehabilitation per se is something that it can improve patients. And also several ataxic patients, congenital ataxia patients, have only motor coordination disabilities, but they don't have any intellectual disability. So it's very relevant to distinguish if that given patient has only coordination difficulties, but not there's no relation to, or the same patient has no problems in the intellectual side, and that has to be in some way highlighted because, you know, in the follow-up and also in the school integration, it's relevant to know all this. So the rehabilitation side is very important, not only for rehabilitation, but also trying to define the intellectual levels and the motor difficulties and so on. On the other side, we have a unit of genetics that is completely involved in this. So we try to, in this way, we try to, well, increase efficacy and also the reduce the time frame and the turnaround time for having a genetic diagnosis. And then we also have an outpatient clinic that is made up of from geneticists, but also from neurologists that are expert in the field, you know, to start with the first, to start on the procedure. So the diagnostic procedure, you know, it's relevant because sometimes you really need to go back and forth with a genetic lab in some difficult cases in which you have to define. It doesn't pop, you know, the diagnosis doesn't pop up at the first line of diagnosis. So you have to discuss and with what the clinician has, MRI and clinical aspects that then can, going back and forth, you can help to define the diagnosis in ataxic patients. So there were different units. We're the unit of neurology, the unit of genetics, and the unit of neurorehabilitation are mostly involved in all the network.
Wonderful. Thank you for that explanation. And we have one last question that has been submitted right before the end of this talk. We have someone who's shared that her sons have, she has two sons, 4 and 7, that have an unknown suspected genetic forms of ataxia. They have had whole genome sequencing, whole exome sequencing, and the panel for triplet repeat expansions. Are there any other tests for genetics that should be considered if these ones have already ruled out known forms of ataxia? Are there any other types of tests available?
So in this family, 2 children, 2 SIBs are affected.
Yes.
So possibly there's and they are males, females?
Males.
They're both males. It could be also an X-linked disorder or a recessive disorder, X-linked recessive or autosomal recessive. You know, to answer to this question, it would be relevant to know more about the MRI and also the clinical history. I mean, if it's congenital onset or if it's progressive or static, if it's early onset or you know, some details on that would be relevant. And also know more about the MRI. Is there any hypoplasia of the cerebellum or atrophy of the cerebellum? And what about, you know, many other information about this? I mean, so it would be relevant, important to know these details. Otherwise, it can be perhaps as a methodology, after a whole exome sequencing, we proceed into a whole genome sequencing.
They have done it. They have done it, the whole genome, but I suppose it's a short read with genome.
Oh, so maybe long read sequencing would be a better fit for this
at the
family?
same time, I was wondering who did the. It's very important to know which center did the test. If like a service or it's a university hospital, it's very important to know.
Okay, that's true, because there's different testing centers offer different options. It seems that this particular case may be a little bit more complex, but I would encourage this particular viewer. We have a list of different ataxia centers of excellence that provide comprehensive care, like the team at Bambino Gesù. If you would like, please do reach out to them. There's information available on their website. They'd be able to work with you and a little bit closely, get more context on your family history.
Exactly.
And maybe work with you to find an answer.
Reanalyze also the data, the sequencing, the data of sequencing.
On one side, and I would say reanalyze also the genetic and neuroimaging, at least to see if you have some idea. I know, but it's similar to patients that you have already seen in the past or so on.
All these different clues that are put together to try to find an answer.
You have to go back and look at all the different clues again. That's what you have. It's better to do.
Mm-hmm. Well, yeah. Well, Dr. Zanni, yeah. Dr. Zanni, Dr. Bertini, thank you so much for spending this hour with us and letting us know a little bit more about X-linked cerebellar ataxia. We really appreciate it.
Thank you.
Thank you.
For inviting us.
And
bye.
And to everyone who was listening to the talk, I hope you found this valuable. And wherever you are in the world, good morning, good afternoon, good evening. Have a wonderful rest of your day. Take care, everyone.